All right. For our fourth and final lecture, it's my pleasure to introduce Dr. Thomas Listopadzki, who will be diving into a little bit more detail on X-ray reading, building on Dr. Moghdateri's earlier Foundations of X-rays lecture. Thomas is a PGY3 at the University of Buffalo. He completed med school at the University of Buffalo and is interested in pursuing a career in total joint arthroplasty. So, Thomas, over to you.
Hi, everyone. Like I said, my name's Thomas. I'm one of Ellen's co-interns, and so I just wanted to tell her thank you for her help in putting this slideshow together. This is going to go more in depth into how to read specific types of X-ray. So in this presentation, I'm mostly going to just focus on wrist films. We can move to the next slide. Um, yeah, so sorry. I think this might be an older slideshow. One second.
Sorry, Thomas. If you have a newer one, we can use
I
that
can
one.
share. I can share too if that works.
Okay, is that easier for you?
Yeah, I mean, if you guys have the other one, you guys can share that. Otherwise, I can also just share what I have.
Um, I think it might be easier if you share, if that's okay.
Yeah, for sure.
Awesome, thank you. Sorry about that.
No worries. All right. So let me. Is everyone seeing that pretty well?
Yep, that's good.
Okay, perfect. So there's just a few basics to just reading an X-ray. So whenever you're going through an X-ray, there's a few things you kind of always want to categorize how you're reading them. A lot of things in being successful in residency is general and is finding some way of doing the same thing the same way every single time. And so when you're going over an X-ray, you kind of want to use the same framework to read over each X-ray the same way, so that if you see something pretty commonly and then see something out of the ordinary, it's a lot easier to catch it. So if you have this framework in mind, then it's a lot easier to make sure you're finding everything. So the first thing you want to look at is the location of where the X-ray is taken. So take into account the laterality, is it left to right? Take into account the skeletal maturity of the patient. Are they a kid with open physes, or are they an adult where their physes are closed? You want to know the type or the part of the bone that you're talking about. So is it proximal distal aspect of the bone? Are you in the metaphysis, the epiphysis, the diaphysis? And then if there is a fracture, is there any kind of articular extension of that fracture? Then after you think about pattern, you want to look in the or if you think about location, you want to look into the pattern. So is it comminuted? Is there more than one fracture? Are there multiple smaller pieces? And then talk about the shape of the fracture, if it's transverse, oblique, spiral, or butterfly. And then you can talk about the relative alignment of the bones in that fracture. So is there any kind of translation? Is there any angulation, or is there any type of shortening from the fracture? And so then just as a quick example, of something I'll go into a little bit more. If you're looking at this specific X-ray, one way that you could talk about it is we got an AP and a lateral of a left wrist in a skeletally mature individual that's demonstrating a comminuted metaphyseal distal radius fracture with intra-articular extension. There's also dorsal angulation, or you could say apex volar, and there's also loss of radial height inclination. One of the other things that you could mention about this is with there being with it being dorsally displaced, that there's loss of volar tilt, but I think just by virtue of saying it's dorsally displaced, it kind of implies that there's loss of volar tilt. So with X-ray specifically, some of the most common views that you're going to end up seeing are an AP lateral and an oblique. When you're first looking at evaluating a patient, say in the emergency room, who has some kind of obvious deformity of the wrist, these are probably the views that you're going to get. But that's not necessarily the only views of the wrist that are possible. You can also get a carpal tunnel view, which is that one on the top left. Specifically, these are helpful when you're looking at hook of the hamate fractures. You could get clenched fist views, which are on the bottom left, and those are specifically looking for widening between the scaphoid and the lunate bones, so widening the scaphoid-lunate interval. And you can also get scaphoid views. With one of them that I just highlighted here is an ulnar deviation film, which is just supposed to bring the scaphoid into better view. And obviously, a lot of times when we talk about wrist fractures, we're only thinking about the proximal portion of the joint, but the wrist is really the radiocarpal joint. And so you want to know what all the different carpal bones are too. So the saying or the phrase that I remember is "so long the pinky, here comes the thumb." But basically, on the bottom row, you've got the scaphoid, the lunate, the triquetrum, and then you've got the pisiform. And then as you go back from ulnar to medial, you've got the hamate, the capitate, the trapezoid, and the trapezium. And then with the little stars, you've got the radial and the ulnar styloids as well. When you're looking at a PA view or an AP view, there's a few things that you want to take into account. You're going to think about the radial inclination, which is basically the slope that the radius makes when going from radial to ulnar. That's usually about 22 degrees. And then you also want to consider the radial height. So usually, obviously, it varies on person to person, but the average radial height's about 11 millimeters. And that's basically measuring from the tip of the radial styloid to the base of the lunate fossa, which you can see kind of described there in the picture on the bottom. And then you can also look at the ulnar variance, which is basically looking at how much space there is between the carpal bones and the ulnar styloid. Some people will have either positive or negative ulnar variance, and that can be normal for them, or it could be abnormal for them and cause some kind of pathology. It's not necessarily something that we, mention in every time that we take a look at a wrist X-ray, but it's something to consider if you're trying to evaluate someone with wrist pain. And then you can also look at whether or not the DRUJ is intact. If it looks like the distal radial ulnar joint is intact. One second. Sorry, had a little malfunction here. Alrighty. Everyone still hear me okay?
Yes.
All right, perfect. Thanks. And then when we're going to the lateral, with every kind of X-ray, there's certain parameters that we try to take into account to make sure that we have an appropriate lateral. Obviously, you can imagine that the wrist, there's a variety of ways that you can hold your wrist, and slightly different directions that an X-ray beam could take to give slightly different appearances of the overlap of the different carpal bones. Sometimes someone may ask you to critically evaluate whether or not it's a good lateral of the wrist, and what they're really looking at is trying to place where the pisiform is in relationship to the scaphoid. So for these lateral X-rays, you generally want to have the pisiform in the anterior or the volar 1/3 of the scaphoid. If you see that the pisiform is overlapped differently, then you know it's not a totally appropriate lateral view. And outside of just criticize or determining whether or not it's a good lateral, the one other thing they want to take a look at is the degree of volar tilt. And so it's basically looking at how volarly tilted the distal radius is. Normally, it's about 11 degrees. As if you guys remember from the X-rays initially, there was a lot of loss of volar tilt from the dorsal displacement. And so that's something that you can, critically discuss as well when you're evaluating these films. There are a small handful of different classification styles for distal radius fractures. I've kind of found the one that I use most commonly, and that we tend to use to communicate most effectively, is the eponym classification. So this basically just describes fracture patterns based on different names. So some of the most common ones that you're going to see are the Colles and Smiths fractures, which is basically just like an extra-articular distal radius fracture, either with dorsal or volar angulation. So if it's dorsally angulated, then it's a Colles fracture. If it's volarly angulated, then it's a Smith's fracture. You could also have Barton fractures, which are intra-articular distal radius fractures with some subluxation of the radiocarpal joint. And that can be subclassified into either a volar or a dorsal Barton fracture based on the direction that the radiocarpal joint is going. Then you can also have lunate dipunch fractures, which is just a very specific type of intra-articular depressed fracture where the lunate kind of punches in part of the lunate fossa in the distal radius. And then there's also Chauffeur's fracture, which is just a fracture of the radial styloid. And then the forearm and the wrist specifically can be kind of complicated when talking about alignment. So one of the things that we mentioned is translation. And when you're talking about translation, you want to consider what direction the distal portion of the fracture is going. Kind of similarly to dislocations or like in ankle fractures, but in this case, in the X-ray example on the right, we've got radial translation because the distal portion of the forearm is translated in the radial direction compared to the proximal portion. We've also got, talking about angulation, there's two different ways that we can do that. We can either talk about deviation, which is what we've got here. And when we're talking about deviation, we're again looking at the direction that the distal portion of the fracture is in relationship to the proximal. So in this case, our fracture has got ulnar deviation because the distal portion of the forearm is pointed ulnarly compared to the proximal portion. But in some situations, we may also talk about a fracture's apex radial or apex ulnar. Is less common in the AP portion of the forearm, as it is more so in the lateral. But this fracture could be described as apex radial, meaning that if you think about the side of the fracture that's convex and the side of the fracture that's concave, or if you try to make an arrow like is demonstrated here, the direction that the arrow is pointing is the direction that the apex is. So if you think also about this like being a mountain tip, then the tip of the mountain is the direction that the apex is. And the computer's crashed again. 1 second, sorry guys. All right, there we go. And then we can talk about alignment too. In the lateral, this is more so where we talk about apex volar or apex dorsal, but you can also talk about volar or dorsal angulation. So in this case, if we have a fracture where this is a more common fracture patterns in like a younger kid, I think with a green stick fracture, we could have a apex volar or we could have a dorsally angulated forearm fracture. And so I'll just go through a couple of x-rays kind of putting this into practice. So here we have a AP at a lateral and oblique of a left wrist, which is demonstrating in a skeletal immature individual, demonstrating a intra-articular depressed distal radius fracture in the metaphysis. So this is, if we were looking at the eponym classification, this would be more of a die punch fracture. And then if we're thinking about this case, this is an attempted AP in a lateral of a skeletally immature individual demonstrating a ulnarly deviated and apex volar or dorsally angulated radial and ulnar diaphyseal fracture. This is more of like a green stick fracture in a younger kid. And that's everything I got. Does anyone have any questions? Sorry, that's a lot to talk about. But that's kind of what we do when we're specifically looking at just wrist frames.
Awesome. Thanks so much, Thomas. This was great. Super helpful for everyone. This is our finale to our lecture series, which has definitely been awesome to build up our knowledge of X-ray reading and preparation for our sub-Is. I know we'll all make sure to use these tips over and over as we practice our X-ray reading skills. So before we dive into the rest of the day, we're going to catch up and take a little bit of a break. So we'll take about a 5-minute break and come back at about well, actually, we'll take a little bit longer. We'll come back at 1:25. And so everyone stretch your legs, get a drink, bite to eat, and then we'll come back at 1:25 for our final panel of the day. Thanks again, Thomas, and our awesome lecturers.